So we're still talking about surgical infection. This section will deal with the localized infection. So we'll first grade and score the wound according to various grading and scoring systems. Then we'll take a look at what an abscess actually is, and finally we'll talk about cellulitis and lymphangitis. So starting off with Southampton wound grading system. So we can divide a wound from grade 0 to grade 5. We'll see how we progress from grade 0 to grade 5. So grade 0 wound is a normal healing wound. A wound which appears normally healing is a 0 grade wound. Grade 1 wound is a normal healing wound with mild bruising or erythema. So you might see slight bruising or erythema, so you will assign grade 1 to the wound. Now grade 1 has been further divided into 1A, 1B and 1C. Now 1A has some bruising. Now 1B has considerable bruising. And 1C has erythema. So 1A and B are divided on the basis of presence of bruising, mild and severe, and then 1C has erythema all over the wound. Now category 2 or grade 2 wound is erythema plus other signs of inflammation. So along with erythema, if there are other signs of inflammation, this is a grade 2 wound. Now again, grade 2 wound is further divided into 2A, 2B, 2C and 2D. So in 2A, we have erythema and signs of inflammation at one point in the wound only. Now in grade 2B, we have erythema and signs of inflammation around sutures. In grade 2C, we have erythema and signs of inflammation along the wound. And in grade 2D, we have erythema and signs of inflammation all around the wound. Now let's come to grade 3 of a wound. In grade 3, there's clear or hemoserous discharge. So when a wound starts discharging, it goes to grade 3. Now grade 3 is again divided into 3A, B, C and D. 3A is the discharge at one point only, and this point is less than or equal to 2 centimeter. Now 3B is clear or hemoserous discharge along the wound, and this is greater than 2 centimeter. Grade 3C has a large volume discharge, and grade 3D is prolonged discharge for more than 3 days. Now after grade 3, we have a wound with major complications. So grade 4 and grade 5 represent wounds with major complications. So a grade 4 wound is a wound that is extruding pus. It is further divided into 4A, which is at pus which is being extruded at one point only, and this point is less than or equal to 2 centimeter. In grade 4B, we have pus all along the wound, and this is greater than 2 centimeter. Now in grade 5 wound, there's deep or severe wound infection, which may or may not include tissue breakdown and hematoma formation requiring aspiration. So this is the Southampton wound grading system. Not very frequently used because of its extensivity, but an important grading system. We have the asepsis wound score as well. Now in this, first of all, we have additional there are points associated with this. So additional treatment, they are given points for additional treatment. If you use antibiotics for wound infection, you mark 10 points. Then there's drainage of pus under local anesthesia. If this occurs, then you give 5 points. Then there's debridement of wound under general anesthesia. If this happens, there's 10 points. If a wound is discharging seriously, now the first 4 of these are measured daily for 3 days. Now, if the wound is discharging seriously for it is discharging daily, you categorize it from 0 to 5. Then erythema is categorized from 0 to 5 again. Then purulent exudate is checked and categorized from 0 to 10. Then separation from the deep tissue is also categorized and is categorized from 0 to 10. Now, isolation of bacteria from wound can only be done after 3 weeks, and stay as inpatient is prolonged over 14 days. As a result of wound infection, you mark 5 points for that as well. This is the asepsis wound score, again not commonly used, but it's still there. So, talking about the localized infection. So we have an abscess. First of all, what is an abscess? An abscess presents all the clinical features of inflammation which are originally described by Celsus. So what were these features of acute inflammation? These were the calor, which is heat, the rubor, the redness, the dolor, the pain, and the tumor, swelling. Here you can see this is an abscess. It has it is warm to touch. It has redness all around. There's pain when you touch it, and there is swelling in the area. So this is an abscess. It is also associated with functional liaisa, that is the loss of function. So it is also associated with the loss of function. Now, the pus is composed of dead and dying white blood cells. So, hence the color. The pus is composed of dead and dying white blood cells. So, what makes the surroundings of the abscess? So, the surroundings of the abscess are made up of a fibrinous exudate and edema in cells of acute inflammation. So, we have a fibrinous exudate. We have edema, and we have cells of acute inflammation. Now there's granulation tissue in the area. This granulation tissue consists of macrophages, the fibroblasts, and new blood vessel proliferation. This forms later around the suppurative process and leads to collagen deposition. So this granulation tissue is trying to heal this abscess. This actually first it lays down macrophages. These macrophages tend to destroy this dead and dying white blood cells. Then the fibroblasts are there and new vessels are there. These fibroblasts being supplied by the new vessels, they lay down the collagen after the suppuration process has ended. Now there's hyperosmolar material around the area as well. This hyperosmolar material within the abscess, it draws in fluid and increases pressure and causes pain. So what happens? The fluid in the abscess, it becomes hyperosmolar. When it's hyperosmolar, it draws further fluid inside. As a result of drawing of further fluid inside, there's increase in pressure, and this increase in pressure is perceived as pain. Now, if this spreads, it can spread along the planes of least resistance, and they usually point towards the skin. So this is how a channel is made from the abscess, and the abscess is drained. So the wound abscess may discharge spontaneously through the channel that was made along the path of least resistance towards the skin, and they may discharge by spontaneously tracking to a surface, but may need drainage through a surgical incision. The abscess may drain itself through a tiny opening in the skin. However, all of the contents of the abscess are not completely drained. So to completely drain the abscess, you need surgical incision. So most abscesses relating to surgical wounds, they take about 7 to 10 days to form after surgery. So an abscess appears about 2 weeks, 1.5 to 2 weeks after surgery. So this is what an abscess looks like. This is an abscess. So let's talk about the management of an abscess. So if not drained or resorbed completely, it forms a chronic abscess. So we've talked about it. It may drain itself through a channel which is formed along the path of least resistance, leading to a small opening in the skin. However, you may have to perform a surgical incision and drain the abscess, or it may be resorbed completely. All the materials within the abscess might be resorbed. Now, if these two fates do not occur, it may develop into a chronic abscess. Now, if the abscess is partly sterilized with antibiotics, it will form an antibioma. So, antibioma is an abscess that is partly sterilized by antibiotics. Now, the modern images techniques may allow guided needle aspiration. So you can aspirate the contents of the abscess. Antibiotics are indicated if the abscess cavity is not left open to drain freely. In this condition, you require antibiotics. However, the preferred method of treatment of an abscess is draining of the surgical drainage of the abscess and healing by secondary intention. An open abscess cavity heals by secondary intention itself. So, referring to the figure again, so this is an area where the abscess has been formed. So skin above the abscess is open with a surgical knife. Here you can see along this line, the skin is open. Abscess cavity is drained and cleaned. So this cavity is open, it's completely drained and cleaned. Now sometimes the doctor will pack a gauze in the abscess cavity with a ribbon gauze and leave a short wick outside of the wound. Now the gauze allows any new pus that collects to drain out. Now this gauze, it will be gently pulled out little bit each day, so that new forming pus can be drained each day, as well as this cavity can heal from the inside. So when the wick is completely removed, the cavity has been healed. So what is a chronic abscess? So chronic abscess leads to sinus or fistula formation. So abscess has been there for quite some time. Now it keeps on trying to drain through the path of least resistance through a skin opening. This skin opening might lead to formation of sinus or a fistula. Now lymphocytes and plasma cells are seen in a chronic abscess. There's tissue sequestration, that is, tissues are trapped, and there is later calcification, which can be seen on imaging as well. Now, the common causes are the Mycobacterium and Actinomyces. So, Mycobacterium and Actinomyces are responsible for the production of chronic abscesses in humans. Now, ultrasounds, the CT scan, and MRI may be helpful. It is important to know that X-rays, the radiography is not very helpful in chronic abscesses. Now, anastomotic contamination may be the cause of abscess maybe the most common cause of abscess, but in the abdomen, abscesses are most usually the result of anastomotic leakage. So in abdomen, anastomotic leakage is the most common cause. Otherwise, the anastomotic contamination may be responsible for the production of a chronic abscess. Now let's talk about cellulitis and lymphangitis. So cellulitis is a non-suppurative invasive infection of the tissues, which is usually related to the point of injury. So what happens in cellulitis, there's non-suppurative invasive infection of the tissues. And this infection of the tissues is usually associated with a point of entry. So there's poor localization in addition to the cardinal signs of spreading inflammation. So there's poor localization. You cannot exactly mark out where the infection is taking place. So there's tissue destruction, there's gangrene and ulceration. which are caused by the release of proteases. So all the signs of inflammation, then finally the fate of inflammation can occur. The blood cultures are often negative. This is very important, that the blood cultures are often negative. So the causes might include the beta hemolytic streptococci, the staphylococci, and Clostridium perfringens. Hey, in the figure you can see this is the cellulitis we are talking about. So lymphangitis is part of a similar process and presents as painful red streaks in affected lymphatics which are draining the source of infection. Here you can see this is the cellulitis, and these are the infected red lines which actually show these are the painful red streaks, and they are showing the lymphatics which are draining the affected part. So this is cellulitis and lymphangitis. Cellulitis, the inflammation of cells which is non-separative and associated with the point of entry. Lymphangitis, inflammation of the lymphatics which are draining that particular area. So this was all about this section. I hope you liked and enjoyed this section. For further such sections, keep watching sqadia.com.